Hello and good evening all. And today's episode of the General Surgery lectures is going to be on the pathogenesis and management of septic shock. Septic shock or shock generally is a very important aspect in surgical practice because most of our patients in surgery, ultimately, those who die, they die from one form of shock or the other. So shock is a very important aspect in surgical practice where a surgeon or any attending physician also should have a detailed knowledge in the pathogenesis and management of shock. So today, Dr. Magaji is going to be discussing on one aspect of shock, which is very important, especially those who end up in the intensive care unit, septic shock. So septic shock, it's very important for you to understand the pathogenesis. This will give you the foundation in getting the basis of all the various aspects of its management. So Dr. Magaji, you can go ahead and commence your presentation.
All right, sir. Thank you. Good evening, everyone. I'm Dr. Magaji, a registrar from the Department. I'll be presenting pathogenesis and management of septic shock today. I'll be using this outline. So by way of introduction, shock is the clinical manifestation from a reduction in the effective circulating blood volume. Shock is the most common cause of death among surgical patients, especially commonly hypovolemic shock, seconded by septic shock. Hence, every surgeon must understand the pathophysiology, diagnosis, as well as priority in management of any patient that has septic shock. The concepts and understanding of sepsis over time has evolved. This is as a result of acquisition of more knowledge about sepsis pathophysiology, the etiological factors, the clinical progression has increased and improved remarkably over time. So in the year 1991, there was consensus definition. In the year 2001, which gave rise to sepsis 2. And then the recent definition was given in the year 2016, termed as sepsis 3. So septic shock results from moderate to severe sepsis or tissue damage. It is considered as part of a spectrum and a progression of a systemic inflammatory response syndrome. So from an infection, the body responds via a systemic response, giving rise to the systemic inflammatory response syndrome. From there, patient progresses to sepsis, from sepsis to severe sepsis, septic shock, and then ultimately multiple organ dysfunction syndrome. So this is just a slide showing the spectrum of sepsis. So below is the criteria to diagnose systemic inflammatory response syndrome. Presence of 2 or more of these qualifies a patient to have systemic inflammatory response syndrome. So from sepsis 1 and 2 definition, there is no much difference between sepsis 1 and 2. So basically, the following definitions are from sepsis 2, that when there is systemic inflammatory response syndrome, and then there is a clinical focus of infection, such a patient is said to have sepsis. Then in the presence of sepsis, if there is an organ dysfunction, the term to be used is a severe sepsis. Then in the event that there is associated shock, which cannot be reversed by adequate fluid resuscitation, in which pneumotension is maintained by ionotropes, the patient is said to have septic shock. So in the presence of severe sepsis and refractory hypotension, which is refractory to fluid resuscitation, or the patient requires inotropic support to maintain the BP at a normal value, such a patient is said to have septic shock. That's the definition by sepsis 2. Then in 2016, the working groups on sepsis 3 defined sepsis as life-threatening organ dysfunction caused by a dysregulated host response to infection or any other insults other than infection. And then septic shock was defined as a lactate level above 2 millimoles per liter without hypovolemia. So you have to exclude hypovolemia either from hemorrhagic shock or other causes of hypovolemia. Then, or initiation of vasopressor treatment in order to maintain the arterial pressure above 65 millimeters of mercury. Sepsis and septic shock are common problems encountered with multiple organ dysfunction are the leading causes of death in non. The mortality is quite high. For sepsis is 16%, then it increases to 20% for those that develop severe sepsis, and it increases up to 46%. Mortality rates in children as well as in the elderly tend to be higher compared to the other group. This may be related to probably immunosuppression or underdevelopment of the immune system in children, and then immunosuppression in the elderly. So this a diagram showing the etiological factors of sepsis. Initially, sepsis was it has been established that other bacteria can also constitute 30 to 50%. Gram-negative constitutes 25 to 30%. Then polymicrobial is seen in 11 to 19%. Then other causes like fungus, rickettsia, and viruses can also cause sepsis. For us in surgery, there are certain focus of sepsis, commonly endogenous or exogenous. The endogenous sources include skin, surgical site infection, which is why when you are evaluating your patients, for any patient that you think has sepsis, you must look for the cause. And one of the causes is a surgical site infection. Secondly, urinary tract infection, especially patients with an indwelling urethral catheter. Then respiratory tract infection. Then under the gastrointestinal tract, it may be preoperatively, patient may be septic or may develop sepsis after the surgery, especially patients that will have bowel surgeries for perforated viscous. Then exogenous causes include surgical instruments, drapes, imaging machines we use in theater, and it may be from the staff. So these are risk factors for developing sepsis and by extension, septic shock. Age less than 10 and then more than 70 years. Then if there is presence of malnutrition, anemia. Then the primary disease, if there is a malignancy, diabetes, mellitus, these are immunosuppressive conditions. Then other immunosuppressive agents, especially patients on steroids or those that have received chemotherapy. Then presence of necrotic tissue, hematoma, this will serve as nidus for infection. Then poor surgical technique. In such techniques, there may be extensive devascularization of tissue, which will also serve as a nidus of infection. Then catheterization, especially if sepsis, prolonged hospitalization, which is why, as part of the preventive measures, we tend to admit our patients very close to the surgery day, and then we discharge our patients early. This is just to minimize acquisition of hospital-acquired infections, which may be very difficult to treat. Then presence of major surgeries, and then trauma and extensive. So the pathogenesis, septic shock results. So once there is a presence of a microorganism, or there is tissue damage or burns, the tissue releases some molecules from the microorganisms, or some intracellular molecules from tissue damage, which are categorized into two. We have the damage-associated molecular patterns, which is what the cells, the immune cells recognize, and then the pathogen-associated molecular patterns. In case of gram-negative bacteria, it is the lipopolysaccharides, which has a lipid A moiety. So it is that lipid A moiety system. So how is the immune a prototype?
Dr. Magaji, you are not audible.
Okay,
We can't hear you.
can you hear me now?
Yes, please go ahead. I think your network is bad.
Okay. So the immune system is activated in two stages. There is activation of the macrophages initially, then activation of other inflammatory responses. So as soon as the bacteria is lysed, the lipopolysaccharide is released, which then binds to lipopolysaccharide binding protein. So these two components now bind to CD14, which is on macrophages. The lipopolysaccharide binding protein is now released, leaving the lipopolysaccharides and the CD14 attached to the macrophages. This then attaches to toll-like receptor 4, which is present in most inflammatory cells and antigen-presenting cells. So once this is attached to the toll-like receptor, there is transcription of pro-inflammatory genes, which produces tumor necrosis factor alpha, interleukin-1, and interleukin-12. So it is these cytokines that actually affect the damages that leads to the manifestation of septic shock. So there is alteration of the endothelial cell adhesiveness, which now leads to the recruitment of neutrophils that liberates free radicals, causing vascular injury. There is also a promotion of the nitric oxide synthase, which now produces nitric oxide. So this agent causes vasodilation, and by extension, once there is vasodilation, peripheral resistance decreases, leading to hypotension. Then the second stage is activation of other inflammatory responses. There is activation of the complement pathway, whereby we have the C5a and then the C3a component of the complement pathway. This causes microemboli and endothelial damage. Secondly, there is activation of mast cells. As we know, mast cells also tend to release histamine, which is a potent vasodilator and also increases vascular permeability. Then activation of the coagulation system, which enhances thrombi formation, which is why sometimes patients with sepsis may come down with DIC. Then finally activation of the kinin system. That is release of bradykinin, which is also a potent vasodilator that also increases capillary permeability. So the end results of all this is one, vasodilation and increased vascular permeability with profound peripheral vasodilation and pooling of blood. So DIC, as I've said, may develop due to the widespread endothelial damage and as well as activation of the coagulation system. Then there is reduced blood flow, which produces hypotension, inadequate tissue and cellular perfusion. So once there is inadequate perfusion at the cellular level, the body naturally switches to synthesis of lower ATP as compared to the high ATP value of 38. So this now leads to the failure of the sodium potassium pump. This results in leakage of potassium cells outside the cells, and then there is influx of sodium into the cells. So as sodium is moving into the cells, it carries along water into the cells, causing cellular swelling, and subsequently the cell may eventually lyse. This finally leads to organ dysfunction and failure at the end of the day. So these are some of the complications that can arise. There is acute kidney injury, which is one of the commonest complications in patients with sepsis and septic shock. Then there is DIC, adult respiratory distress syndrome, multiple organ dysfunction, and then DVT. So for the management, it is important we know that this is an emergency, and as such, it should be managed as such. There is the Surviving Sepsis Campaign Bundle, which should be initiated within 1 hour. So as soon as you recognize that this patient has sepsis or septic shock, so this bundle should be activated. It is divided into two. The first part should be completed within 3 hours. First, you measure the lactate level. Then secondly, obtain blood cultures prior to the administration of antibiotics. Then administer broad spectrum antibiotics. Then you commence fluid resuscitation with 30 mils per kg of crystalloid. Normally we use normal saline. And then the second part should be completed within 6 hours. You apply vasopressors. That is, by the time you finish giving your crystalloids and then you are still battling with hypotension, you are not able to maintain mean arterial blood pressure of 65 or more, then you should go ahead and commence vasopressors. This should be done within 6 hours of your diagnosis. Then in the event of persistent arterial hypertension, despite volume resuscitation, you are expected to measure the central venous pressure as well as measure the central venous oxygen saturation. And then finally, you remeasure the lactates if the initial measurement was high. So these are the aims of management of patients with septic shock. You want to improve the hemodynamic state, restore tissue perfusion, thereby increasing oxygen delivery to the tissues. Establish a focus, which is very important because without eradicating the focus, the sepsis will persist. Combat bacteria and cytokines, then eliminate the septic focus, prevent or treat complications if they arise. So the resuscitative aspects, This tends to follow the ATLS protocol, even though this is not trauma, but in as much as possible, you want to apply such protocol in management of this patient with septic shock. So you ensure that the patient has a clear patent airway, then commence oxygen delivery via face masks. In some instances, you may have to intubate the patient and ventilate. This tends to reduce the work of breathing, as well as improving the oxygen saturation. Then secure IV access using white bulk cannula crystalloids to be given at 30 mils per kg within the first 4 to 6 hours. Then further fluid resuscitation will be guided by your endpoints of resuscitation, which you want to monitor, which include both the clinical aspects. You want to be checking the pulse rates, the BP, central venous pressure, as well as laboratory parameters, your serum lactate. Despite adequate fluid resuscitation, patient still is hypotensive. So you want to commence inotropic support, given catecholamines. The first line drug there is norepinephrine, which may be followed by epinephrine. Then sometimes you want to use arginine vasopressin in those who develop arterial resistance to the catecholamines. Then for patients who develop cardiac dysfunction, you will use dobutamine, either alone or in combination with norepinephrine. So having resuscitated your patient, you want to establish the focus. This can be done through our normal routine of taking history, examining the patient, and then evaluating further. So in the history, you wanted to know the age of the patient. As we have seen, these factors include age less than 10 years, and then in the elderly, more than 70 years. Then commonly, there may be jaundice, especially if there is a end organ dysfunction, altered sensorium, then oliguria, if this develop. Then symptoms from the affected symptoms. If this patient is coughing, having difficulty in breathing, it may suggest the focus may be from the chest. There may be discharge from an upside, and so on and so forth. Then past medical history. Here you want to establish any risk factor: diabetes, mellitus, HIV, or if the patient has had splenectomy. As we know, patients who have had splenectomy are subjected to overwhelming sepsis. Then drug history, immunosuppressive agents. On examination, if it is in the early stage, patient may still be febrile with warm, dry, flushed skin, may be hyperventilating, and the pulse characteristically is bounding. This is as opposed hypovolemic shock, whereby the pulse will be faint or thready, and then the patient will have cold, clammy extremities. Then in the late stages, there may be altered sensorium, cold, clammy skin, feeble pulse, hypothermia, hypotension will persist, and then there may be jaundice. Then systemic examination in an attempt to establish the focus. You want to examine the chest, presence of crepitations or bronchial sounds, the suggestion of pneumonia. Abdomen, you want to check for signs of surgical site infection or peritonitis. Musculoskeletal, some of these patients may have bed sores, which may actually be the focus of the infection. There may be a gangrenous limb, that is the focus of the infection. Patient may have indwelling catheter. You may be able to visualize the urine. Some of them, the urine may be cloudy. Then other aspect of the examination, you want to check site of cannulations, because one of the complications of peripheral or central venous access is actually sepsis. So you want to check this site, and if possible, if you think that's the focus, you may have to remove the venous access. So having taken history and examined the patient, you want to investigate. So commonly we want to do a septic workup, which include a blood culture. This should be taken early, as we know blood culture usually takes time. In our facility here, before you even get a result, it may take up to 10 days. So as soon as you suspect, you should take blood culture, then commence empirical antibiotic treatments. Then you want to do sputum MCS if the patient is producing sputum, urine MCS, wound swab MCS. Then based on the suspected source, if you think the patient has a pneumonia, you want to do a chest x-ray, abdominal ultrasound or CT scan if there is an if you suspect an intra-abdominal collection. Then other ancillary investigations, full blood count may show leukocytosis, there may be anemia, there may be thrombocytopenia, especially if DIC has set in, or thrombocytosis in the initial stages. Then EUCR, you want to detect any renal derangements, and LFT, the inclusion profile, because these patients are at the risk of developing DIC. So treatment, you want to commence empirical treatments with antibiotics, even though there are certain sets of patients that the sepsis is not actually from bacteria, but you still want to start the patient on antibiotics, pending when you have your blood culture or other culture results. So commonly we use third generation cephalosporins in combination with metronidazole, which will cover for anaerobes. And the dose we use for ceftriaxone for the septicemic dose is usually 75 milligrams per kg. However, there is a range 50 to 100 milligrams per kg in 2 divided doses. Then as soon as you review your culture results, you want to switch back to the appropriate antibiotic or antifungal, as the case may be, because some of these patients may actually have sepsis from fungal infection. So transfusion is recommended in patients whose hemoglobin is below 7 grams per DL. Then ultimately, this is where surgery comes to play. You must eradicate the source of this infection. Otherwise, patient will never improve. So surgery can be both resuscitative and therapeutic. So if the septic focus is responsible for the septic shock, it should be dealt with as soon as possible, especially if response to therapy is poor. So some of the surgical procedures, depending on your diagnosis, you may want to debride uh, some of the tissues, drainage of abscesses, resection of gangrenous bowel, amputation, and so on. There are some adjunctive measures. Because this is a catabolic state, sometimes they may be battling with hyperglycemia, even though this patient may not be diabetic primarily, but they may have hyperglycemia, which studies have shown that a blood glucose level of 80 to 120 milligrams per DL has been found to reduce morbidity and mortality. So you want to commence glucose, potassium, insulin infusion in order to achieve this glucose control. Then some studies have shown that corticosteroids are helpful, especially in patients who have developed adrenal insufficiency. So giving hydrocortisone at 50 milligrams every 6 hours for a duration of 1 week has been found to be an improved outcome. ventilation. This will help reduce the work of breathing. Enteral nutrition is very, very important. Then prophylaxis for term of dialysis, because one of the commonest complications of septic shock is acute kidney injury. So as soon as that has been established and patient has met the criteria, dialysis should be instituted as soon as possible. So while treating your patients, you want to monitor certain things. There are clinical parameters you measure as well as laboratory parameters. Patients that initially has altered sensorium is now gaining consciousness. You will definitely know that you are winning. And then you have a target of urine output of at least 0.5 mils per kg per hour. Then pulse rates should be measured every 15 minutes. Then blood pressure should be measured both invasively and non-invasively. Pulse oximetry, central venous pressure with a target of 10 to 15 centimeters of water. Then lungs and jugular vein. So you have to be auscultating this patient's lungs, especially in the first few hours when you are giving your crystalloids, in order not to overload this patient with excessive IV fluid. Then laboratory parameters that you need to measure, especially in patient with shock, is the serum lactate. Then others, ECG and echo. Then recent advances in the management of septic shock, there is immunotherapy, whereby it targets some of these cytokines that incite the septic shock. So antibodies to tumor necrosis factor, interleukin 1 and 6. Then there is recombinant interleukin 1 receptor antagonist. Then part of the monitoring, recently there is a resuscitation to pulmonary artery endpoint with hemodynamic optimization and optimization of mixed venous oxygen measurements up to 72 hours after admission to the ICU. So prognosis is not quite good. Mortality is high as 40 to 50%, despite the increases, the advances in ICU care and every other advances. Mortality still remains high. There are some poor prognostic factors. Advanced age is a poor prognostic factor. If the patient is infected with a resistant organism, presence of immunosuppression, if the state prior to admission or surgery is already poor, so the prognosis is bad, then if there is continued need for vasopressor therapy after 24 hours of treatment. So in conclusion, septic shock is a common cause of death among surgical patients. Despite advances in intensive care, the mortality rate still remains high. Therefore, septic shock is better prevented than treated. So these are my references. Thank you for listening.
Thank you very much, Dr. Magaji, for this presentation. As we can see, this is a very important topic in a surgical practice. Despite advances in patient management, the mortality of patients with septic shock is still very high. It's very important. Any patient you are managing with the risk factors that are outlined, you have to be proactive. Because when a patient develops septic shock, progressing into multiple organ dysfunction syndrome, it is difficult to manage. And as you know, not all centers have ICU for adequate monitoring. Now, we will open the floor for comments, questions, contributions. Afterwards, I will now summarize the presentation. So the floor is open for comments, please. If you have a question, you indicate by either raising your hands or you unmute your mic and ask your question. So thank you very much. Okay, we are in a question and answer session and comment section.
Good evening, consultant and fellow colleagues. My name is Dr. Sekina. Thank you for your presentation, Dr. Magaji. Based on your topic, pathogenesis and management of septic shock, I think you didn't really expatiate on the pathogenesis. So I will just start with my contribution before I ask my question. So part of the pathogenesis is important. You didn't mention anti-inflammatory cytokines, because it's important for us to know that anti-inflammatory cytokine, that's 4 and 10, interleukin 4 and 10, they are also produced in septic shock because they help to balance out the pro-inflammatory cytokine. And then they also contribute to immunosuppression in the patient. So it's important for us to know that patients with septic shock are also at risk of immunosuppression. And then also for the DIC, what actually happens is that the tumor necrotic factor activates factor 12, which activates factor 11 and tissue factor. And in turn, this one would activate the intrinsic and extrinsic pathway respectively. So that also contributes to the bleeding we see in such patients. Then, and also in the pathogenesis too, the anticoagulants such as protein C, protein S, they are also reduced. As such, the coagulation pathway is not well regulated, and so the patient can also bleed. So that was all part of the pathogenesis. So my first question is, why is non-epinephrine the first-line drug? What are the properties that makes it the first-line drug in patients with septic shock? Then my second question, what are the biomarkers of sepsis? I know you mentioned serum lactate. What other things can we look at for that can tell us we are dealing with sepsis and septic shock in the patients? Then my final question, in patients, septic shock from a viral source, how can we make a diagnosis? Which investigation should we do? Thank you very much.
Thank you very much, Dr. Sekina, for that wonderful comment and questions. In order not to dodge from this question, Magaji, you should answer the questions before we take subsequent comments and questions.
All right, thank you, Dr. Sekina. For the biomarkers, there is procalcitonin and C-reactive protein. I don't know if there are others.
Yes, go ahead, answer the question. When you are done, we'll ask her if she's satisfied with your answers. She asks 3
All right, sir. Then if we suspect a sepsis from a viral infection, you will do a PCR to detect that. Then the first line, I mentioned the first line drug being norepinephrine. I don't really know the reason why it is the first line drug and not epinephrine.
So you see, you have to go in depth in research. When you are given a topic, you consult widely and also read even journals before making your presentation. So obviously, Dr. Sekina, he cannot answer your questions. So maybe you will help the house by answering the questions.
Okay, thank you, Dr. Magaji, for your response. So for the biomarkers, yes, you're correct.
Sakina, we cannot hear you. Is Dr. Sakina with us?
Just ask. Okay, can you hear me now? Hello?
We can hear you.
Okay, so I said for the biomarkers, yes, you're right. C-reactive protein and procalcitonin is what is being used. C-reactive protein is actually non-specific. It will just tell you that you're dealing with sepsis, but it's not specific. Why the procalcitonin is what is being used currently, because it's more specific. It will tell you that you're dealing with a bacterial infection, so that it will help in your management. Then for the second question I asked about the non-epinephrine, I'm actually not sure of the answer to myself. That was why I asked. Please, did you hear me?
Yes.
Okay.
We have had you. I'm waiting for the moderator.
Okay, sorry, a call just came in and interrupted my network. So any other questions, comments, contributions? You can put up your hands, then, or you can unmute yourself and ask your question. Questions, comments, contributions? Okay, since there are no questions, let me just summarize the presentation. Then I think we'll call it a day. Okay, we have one hand raised. Please, you can go ahead and ask, unmute yourself. Amina Jimo, you can ask question. You can make your comment.
Good evening, sir.
Good evening.
Am I audible?
Yes, please go ahead.
Good evening, sir. Good evening, everyone. Thank you, Dr. Magaji. I'm Amina Juma from Surgery Department, Ahmadu Bello University Teaching Hospital. Why epinephrine is not first of choice as a vasopressor in the management of septic shock is due to the adverse effects. And that's because it's a potent beta adrenergic. So that's the reason why it can further increase heart rate with further demanding for myocardial oxygen supply. And this can worsen the patient's situation, especially patients that have underlying cardiac condition. And also it has significant metabolic effects, which can also complicate the clinical picture and make management of patients with septic shock more challenging, like it causes increased lactate production, hyperglycemia, and also metabolic acidosis. And also it has a strong vasoconstrictive property. While non-epinephrine is a alpha adrenergic gut blocker. And so it has a less cardiac side effects, metabolic effects, and that's the reason why it is more being recommended, and it is evidence-based, based on clinical guideline. And also, one of the biomarkers of, apart from procalcitonin, the commonest one that we are all known of, is also the lactate. It is also very important as it assesses the tissue perfusion patient, which is also very important following resuscitation. And there's this common campaign slogan in the management of sepsis, which is called the sepsis 6. Dr. Mugaji, I don't know if you have idea on that, sepsis 6.
Sepsis
What
6.
is the important in the management of a patient with septic shock? Yes, sepsis 6.
I've not come across that.
Oh, okay. It actually entails 6 modalities. You give 3, you take 3. This is very important, especially the first hour of patient. It helps to improve outcome. It is also an evidence-based, which studies have been carried out on it, and they realize that patients have a successful, more good prognosis, and also a successful outcome in manage them. And this leads to so you give 3, you take 3. So you are going to take blood culture, you take serum lactate, and you take urine output. It's just way of the initial resuscitation of patients, what we do. But they said when more focus is placed on this, patient has a good outcome. And also, we shouldn't forget that management of septic shock is also multidisciplinary approach where everyone is involved so as to improve patient outcome. So the sepsis 6 entails you give 3, you take 3. In the take, you're going to take, immediately you put your line, you are giving IV fluid, you are taking samples and for blood culture and also for serum lactate, and you are giving IV fluid. And you are administering broad spectrum antibiotics. You are going to pass urethral catheter, and you have to assess patient tissue perfusion. So therefore, you have to monitor the urine output. So you see, and then lastly, you are going to administer oxygen so as to maintain the tissue oxygenation and thereby maintaining the target oxygen saturation. Is that clear?
Yes, ma. Thank you, ma.
Thank you. Thank you, sir. Those are my contributions.
Thank you very much, Dr. Aminat, for those wonderful comments, wonderful contributions. Of course, Magaji, you can see your audience are reading more than the presenter. So this is a wake-up call for all those who are presenting subsequently. You have to go to town and read a lot before presenting. So we still have time to entertain more comments, questions, contributions. The floor is still open for questions. Yes, any other question? Okay, it appears we don't have any other questions. So as a way of summarizing the presentation, though Magaji, you did well. You touch a lot of aspects in the presentation. But if you look at the topic, as Dr. Sakina mentioned, your pathogenesis is a little bit shallow. And septic shock is not only an aspect that deals with patient management. Of course, that is the most important aspect regarding patient management. So importantly, how to present your answers if you are asked to discuss on septic shock, being it in an oral exams or in an essay exams. So in a nutshell, as you define sepsis, you started by giving a definition of what shock is, which is, of course, a very common definition. And what a septic shock is also, what septic shock is, okay? Now, the area where I think you need to do more in this presentation is the aspect of pathogenesis. The pathogenesis was not really straightforward and elaborative. Now, you know, ultimately, when infection invades an organism, you give examples of either gram-negative that cause endotoxemia or gram-positive organisms. Now, for gram-negative organisms that produce lipopolysaccharides, the lipopolysaccharides, they bind to receptors on macrophages, okay? They bind to protein receptors on macrophages. And the essence of this is to produce pro-inflammatory cytokines. If these are macrophages, remember, when there is invasion of an organism by pathogenic microorganisms, they target the immune system. The immune system reacts, and when they bind to receptors on the immune system produces pro-inflammatory cytokines. That is the immune cells. They produce pro-inflammatory cytokines. And these pro-inflammatory cytokines, the notable ones are tumor necrosis factor alpha, interleukin-1, interleukin-6. These are very important pro-inflammatory cytokines that are produced when receptors are binded by the invading microorganisms. These microorganisms, the particles from their cell wall, either as a gram-negative that cause gram-negative septicemia or from gram-positive, cause the macrophages to produce pro-inflammatory cytokines. And the aim of these pro-inflammatory cytokines is to stimulate a cascade of that is a cascade that generates secondary mediators of inflammation. Now, these secondary mediators of inflammation are either produced from damaged endothelial cells, stimulation of inflammatory cells, other inflammatory cells like neutrophils and others. Okay, stimulation of complement cascades. Okay, and all these aim at production of what? Secondary mediators of inflammation. Okay. Secondary mediators of inflammations are, you know, the prostaglandins, the prostacyclins, the thromboxanes, the bradykinins. All these are produced from either inflammatory cells, damaged endothelial cells, and so on. And what the secondary mediators of inflammation, they try to achieve 5 major targets. They try to achieve 5 major targets that are involved in the pathogenesis of septic shock. One, they try to reset hypothalamus. And this patient will start having fever. When the hypothalamus is reset, they tend to develop pyrexia, tachypnea, tachycardia because of resetting of the hypothalamus. Okay. Secondary mediators of inflammation can also cause damage of endothelial lining, leading to leakage of serum into the interstitial space. When there's leakage into the interstitial space, you know the effective circulating volume will be lost. Most of the effective circulating volume are now leaking into the interstitial space. There is also peripheral vasodilatation and pooling of blood. Because you know, among these, there's also nitrous oxide. So there's also peripheral vasodilatation, which worsens the effective circulating volume. Okay. These secondary mediators of inflammation are also toxic to the heart, leading to decreased cardiac contractility. So there's decreasing cardiac contractility. If there's decreased cardiac contractility, you know the overall cardiac output will reduce, okay? And also you have stimulation of the complement cascade. What leads to activation of the complement cascade? You know, when there's this leakage of fluids and loss into the interstitium, you have platelet aggregation, leukocyte aggregation, and sluggishness, which leads to microthrombies and widespread DIC. So overall effect of these will lead to cellular hypoxia. That lactic acidosis that is being produced that you monitor in septic shock is because of anaerobic respiration that generates lactic acidosis from the eventual cellular hypoxia that patients develop. So you see all your measures you are taking in the resuscitation and management is to address all these aspects in the pathogenesis. And because there is widespread endothelial damage and injury, most of the time your resuscitation in up to like 40 to 50% is not successful because there is a widespread endothelial injury, a leakage of substances into the interstitial space, which triggers further widespread inflammatory reaction at the cellular level. So this is overwhelming to the physiology of the body. And ultimately, no matter what you do, you already have a system that is already failing. Okay, so all your measures you take, giving oxygen is to address the cellular hypoxia. Giving adequate fluid is to address inadequate tissue perfusion. Giving antibiotics is to address the microorganisms because the microorganisms have already been lysed and released the particles that trigger the intense inflammation. So you will find out that even with your antibiotics, the cascade still proceeds because this process have already initiated a non-reversible mechanisms. So it's very important you understand all these things because that's why you see in the best of centers, septic shock is still challenging to manage. And also you should know the initial resuscitation, after your initial resuscitation, you must mention that septic shock involves also a multidisciplinary approach, depending on the cause as well as the outcome of the patient. You see, after your initial resuscitation, patients will be admitted into the intensive care units because you know you mentioned monitoring of the patient. And for adequate monitoring of patients, you require patients to be admitted into the ICU, the intensive care unit. That's why if you look at the mortality of a patient with septic shock, the mortality is highest in the ICU because that is the ideal place where patients is to be managed. So there are a lot of newer things that are coming up with regards to shock and septic shock, and a lot of researches and advances in the management of septic shock. So I will encourage all of us to read wide and also develop a templates that will cover all the aspects in case you are asked in your exams or in an oral exams. You should be able to answer the question clearly. So I think with these few comments, if there are no further questions, comments, or contributions, then we can stop here. But if there are still other comments or questions, you can go ahead before we maybe close the presentation. So any question? So I think in the absence of any other question, we are going to stop the presentation here. I think Dr. Magaji really did well. He tried. I think he deserves a round of applause. And secondly, next week, the presentation for next week. Who is presenting next week?
Okay, so I'm the one presenting next week. Surgical management of obesity.
Okay, surgical management of obesity. So it's expected that we should all go and read around these topics, and you should read more than the presenter, so that next week we'll be asking her questions she don't know. Okay, so thank you very much, everyone, and we are going to end the presentation here.